So if you see a patient who you suspect is having a seizure, what do you do? Well, the first thing we have to remember is how much time has been going on. It's key to ask the question is, when did this start? Remember, it takes at least 35, probably 45 minutes before a baby or a child is going to have brain damage from continuous seizing. The first thing you should do if you encounter a patient seizing is take your own pulse. Calm down, you have some time. It's not a rush or an emergency. And that's the first thing I see students do on the wards is they get frantic or they get nervous and then they can't think straight. So what I tell people is take your own pulse when you see a baby who's seizing. Then check the time. We need to know how long this seizure has been going on, and we need to take a second to describe the seizure. Look for eye movements. Is this generalized or was this focal and then became generalized? It's important to understanding all these things so we can make the diagnosis later. Focal seizures are often pathologic and involve a problem in the brain, whereas generalized seizures are more likely to be a seizure disorder, or if the child is febrile, a simple febrile seizure. It's important to keep track of the ABCs. This is a common trick test question where they ask a complicated scenario and then the real answer is ABCs. So remember your basic CPR. Place monitors on the child, place an IV if you can, but you can actually reverse a seizure without an IV. In a baby, always get a D-stick or a dextrose level because the glucose being low is a common cause for a child having a seizure and may indicate either a metabolic disorder or a prolonged fasting state. If you're going to treat the seizure, we'll start with midazolam. I prefer to give midazolam through the nose, and the reason I prefer that to, say, rectal Valium is it's a lot easier, say, in a supermarket, to squirt something in a child's nose than to disrobe them and squirt something into their rectum. That aside, it is not commercially available typically to get nasal midazolam compared to rectal Valium, which they sell for quite a bit of money. In the hospital setting, we can also do IV or IM lorazepam. Then we're going to continue to repeat the benzodiazepines at least 2 times until the seizure stops. After multiple administrations of benzodiazepines, we may choose to move on to an anti-seizure med. In children under 1, we would do Phenobarbital, and in children over 1, we usually start with something like Phenytoin. So let's go through these drugs. Phenytoin is a prodrug. It's given at 20 mg per kilo, either IV or IM, and it's given over 10 minutes. Because it's Phenytoin, it can be given a little bit faster, and there's a benefit to that. The downside is it's expensive. Phenytoin is given at 20 milligrams per kilo IV. You may not give it IM, but you have to give it very slowly. As a result, it's a little bit more annoying and takes a little longer for the seizure to stop. Also, it can cause low blood pressure and dysarrhythmias. Phenobarbital is also 20 milligrams per kilo. You can see an easy dosing scheme here. It's better for children typically under 1 year of age, but can cause sedation and a low blood pressure or a low respiratory rate, so be ready to provide some respiratory support.